Hi everyone, and welcome to to Pharmacology. My name is Rachel, and I will be walking through some basic concepts in pharmacology and why it's important that we know them. So specifically for this lecture, we're going to analyze pharmacokinetics and pharmacodynamics and what those mean, and then we're going to use that knowledge to apply them to respiratory medications. More specifically, we're going to apply that to albuterol. Albuterol is a very common drug that we give, and it's important that we not only understand our mechanism of action, but how it's actually broken down and distributed through the body. So with that, what is pharmacodynamics? Pharmacodynamics is the effect that the drug has on us. So pharmacodynamics is kind of what we're looking for when we give a drug, right? I give epinephrine, what do I expect to see? I give albuterol, I expect to see bronchodilation, right? So pharmacodynamics is the end result of the drug that we give. However, before we get to the end result, we have to go through a whole lot of other stuff, which is known as pharmacokinetics. So pharmacokinetics is how the drug moves through the body. And most importantly, it involves absorption, distribution, metabolism, and excretion, aka ADME, of the drug. Okay? So if we take a drug, it has to get into our body somehow, right? So there's plenty of different ways we can get drugs into our body. In the respiratory world, we're most commonly using inhalation, right? But we can also give plenty of drugs IV, IM, sub-Q, orally, rectally, right? How does the drug get into our body? That is absorption. Distribution is, well, how do we get the drug to the place it needs to be, right? If we're giving epinephrine during a code, how do we get epinephrine into our heart, into our lungs, and all that good stuff? Well, we give it IV, right? So distribution can be affected by many factors. So in that example I just gave, fluid status is going to be a really, really big part of that, right? If we're in a code because we were in hypovolemic shock or hemorrhagic shock, that's going to be a problem. Because if I give epinephrine and I don't have, blood to carry it to the places it needs to go, that's a problem, right? It can be affected by polarity, molecular size. That is important as respiratory therapists because our particle size of albuterol and racemic epinephrine are going to be different because they target different things, right? So metabolism is how does the body break down a molecule, right? Depending on the drug, it can be given in its active form or in a prodrug form, which means our body has to break it down before it can be used. And that's all to do with metabolism. Excretion is also a big one. How do we get rid of it, right? If we metabolize something and then it's never excreted, well, that's probably going to end up having some issues later on down the road. So we have to be able to get rid of these drugs that we're taking. Bioavailability is the fraction of originally administered drug that arrives in the systemic circulation. So of this drug I give, how much actually lands in the bloodstream? That's what we're looking at. So if we give a drug IV, intravenously, 100% of that drug is going to end up in the bloodstream, right? So IV drugs are 100% bioavailable. However, if we give something, let's say, via inhalation, very little of that is actually going to get into our bloodstream. So albuterol, for example, has very low bioavailability because it's really supposed to stay in the lungs. Lastly, we have volume of distribution. And volume of distribution is looking at, I'm going to give a drug, and where is it going to go in the body, and how much is going to stay in the bloodstream. So volume of distribution is the amount of drug in the body divided by the plasma drug concentration. Right? And all this means is that drugs travel, right? So for example, propofol. Propofol is given by IV, right? So it's very bioavailable, if you will. However, it is stored in fat cells. So we gave it intravenously, but it somehow ended up in our fat cells. Okay, so that is what volume of distribution is looking at. It's saying that my body is made up of different compartments, intravascularly, fat, bone, muscle, all those good things. And where does that drug go within the body? So we just talked about ADME, but I want to hit on the M part, the metabolism part again, just because this is going to be a huge factor in our dosing of patients. Okay, So age can affect metabolism. As we get older, our metabolism slows down. Our sex can even do that, right? Females will metabolize things differently than males. During pregnancy, we metabolize things differently. During our postpartum period, right? So that is a huge difference in drug metabolism. Our kidney function is going to be a huge one too. If we're in end-stage renal disease, if our kidneys are not functioning very well, we're going to have a hard problem peeing stuff out, right? So our kidneys are responsible for a lot of our excretion. And if we're holding on to those drugs, well, that's probably not a good thing. Liver function is going to be huge too, as our liver is responsible for a lot of the metabolism of the drugs that we give. So the first pass effect is something that I want to hit on, because when we give a drug, IV or even orally more specifically, all that drug has to go through our kidney at one point if it's bioavailable, if it's in our bloodstream. So our liver does a fantastic job of metabolizing things and kind of clearing stuff out and breaking stuff down. So the first pass effect is that when you give a drug, a lot of that drug will be cleared on that first dose. So that's why we often see loading doses or really high first doses of drugs. That's due to the first pass effect. So we have to give more up front just so we can have appropriate levels of concentration in our blood. DDIs are drug-drug interactions. So, for example, if we give two drugs that counteract each other, that would be a drug interaction, just like beta blockers and beta-2 agonists. So beta blockers like propranolol, metoprolol, all those good things, and albuterol kind of cancel each other out almost. So if we have a patient on a beta blocker, and so we're blocking those beta receptors, and then we give a beta-2 agonist, which is supposed to stimulate those receptors, well, we're going to have a problem, and probably not a whole lot of bronchodilation, okay? Lastly, we also clear things out with our lungs and intestines. There's a couple of different things that we clear out with our lungs that are important. However, we will save that for another lecture. So with that being said, let's talk about the ADME of albuterol. So first things first, we have absorption. How does albuterol get into our body? Well, we got to inhale it, right? So when we inhale albuterol, our target is our bronchial smooth muscle. And if we inhale albuterol, since albuterol is a beta-2 agonist, and we'll talk about receptor effects on the next slide, we stimulate that beta-2 receptor on our bronchial smooth muscle, and hopefully we get bronchodilation. The distribution of albuterol is a little bit interesting because we really don't want albuterol to be distributed. We want albuterol to stay inside of our lungs, right? So when we nebulize albuterol or we give it MDI, only about 10-15% of that albuterol is actually getting to where it needs to be, aka our smooth bronchial muscle, right? Of that 10-15%, even less gets into the actual bloodstream. However, when we do get albuterol into the bloodstream, that's when we start to see those cardiovascular effects of that tachycardia maybe, the little jitteriness, those kinds of things. So very little actually gets into our bloodstream. Our metabolism. Our liver breaks down albuterol, if you didn't know. We break down albuterol by sending it through our liver. And lastly, it's excreted mainly about 70% by the kidneys and about 10% actually by the feces. But within 72 hours, 80 to 100% of the albuterol that we gave is excreted from the body. So in about 72 hours, it's all gone. All right, so if we stop cold turkey, give it 72 hours, and we'll have no albuterol in our system. So why do we care about this? Why does this matter in albuterol? The dosing, that's why this matters, right? If our body clears a drug super quickly, we will have to give more of it more frequently, right? Albuterol, we often give albuterol, depending on the situation, about every 4 hours, right? So the half-life of albuterol is 4 hours-ish. So if we have a super sick patient, we don't necessarily want that albuterol falling down to half, right? So if we have a super sick patient who needs albuterol often, we might need to give albuterol more frequently than 4 hours. So that's why this matters. The ADME of albuterol, that is why this matters. So how our body breaks down that drug and gets rid of it affects our dosing. Last thing I want to talk about are receptor sites. So I've talked about albuterol being a beta-2 agonist. So all that means is that a drug binds and then we produce an effect. So albuterol, a beta-2 agonist, binds to a beta-2 receptor and produces bronchodilation, which is the effect. An antagonist does the exact opposite of that. So it binds and then it stops an effect or lessens an effect. So ipratropium bromide, for example, binds a muscarinic receptor to prevent or to lessen bronchoconstriction, right? So if we prevent bronchoconstriction, we're going to keep our airways more dilated. So that is why ipratropium bromide is called a backdoor bronchodilator. A partial agonist or agonist-antagonist kind of is exactly what it sounds like, but it binds and then it just doesn't have the full effect that a true agonist would, right? So that is what a partial agonist is exactly what it sounds like. So we're going to give a drug and it's going to have not the full effect of an agonist, just a little bit of it. And lastly, an inverse agonist feels slightly counterintuitive, but it's going to bind and then produce the opposite effect that an antagonist of that receptor would. So, for example, benzodiazepines. We give a benzodiazepine, and what does our patient do? They relax a little bit, right? So a benzodiazepine is an inverse agonist because we stimulate those receptors, and then it produces the exact opposite effect as stimulating those receptors. So your benzodiazepines can hit on the GABA receptor. So GABA is an excitatory receptor. So if we stimulate the GABA, we're going to get excited. If we give a benzodiazepine, for example, we are going to mellow out.